If you have a nagging pain in your shoulder or upper arm when reaching out, lying on your side, or just getting dressed in the morning, then you might be dealing with a very common problem called subacromial shoulder pain. In today's video, I'm going to explain exactly what that means, why it happens, what you can do to get it better, and when it might be time to consider a scan, an injection, or in rare cases, surgery. I'm Stephen Bunting, and I'm a specialist MSK physiotherapist based in the UK. On this channel, you won't find any gimmicks or miracle cures. Instead, I take a deeper look at the common musculoskeletal conditions that affect everyday people. Everything here is grounded in clinical experience and the latest evidence to help you make informed, confident decisions about your health. Your shoulder joint is a complex structure made up of bones, muscles and tendons that all work together to give you that huge range of shoulder joint movement. The subacromial space is this area between the top of your upper arm bone, the humerus, and a bony shelf above it called the acromion. Running through that space is the rotator cuff, a group of tendons that help stabilise your shoulder joint, and also a bursa, which is a thin fluid-filled tissue that helps reduce friction of the rotator cuff as it slides under the acromion. When the rotator cuff tendons become irritated due to overuse, strain or inflammation, they can cause that distinct pain usually felt over the upper arm region, which we call the sergeant stripe area. There is often a catch of pain when reaching overhead or out to the side, or when reaching behind your back. It's often also painful when lying on the affected side at night. The condition goes by a few different names. You might hear it called subacromial pain syndrome, rotator cuff related shoulder pain, or the older term subacromial impingement, which describes how the tendons and bursa become compressed or impinged during those painful shoulder movements. It's the most common shoulder problem that we see in clinic, especially in people aged between 40 and 65. It can also occur in the older population, but it rarely occurs under 30. The causes of subacromial shoulder pain are often multifactorial. In many cases, there's no single event or injury to blame, which can be frustrating if you're trying to pinpoint exactly what went wrong. That said, typical contributing factors include repetitive strain, such as overhead work or sports, poor movement habits or posture, weakness or imbalance in the rotator cuff, age-related changes in the tendon structure, or sometimes it's due to a sudden spike in activity, like painting a ceiling or doing some heavy gardening. Usually, though, it's a combination of a number of these different factors, but in most cases there's no serious damage. The rotator cuff tendons are often just irritated or overloaded, and that means they can usually recover with the right approach. We often divide subacromial pain into two broad types, primary and secondary. Primary subacromial pain is usually due to a structurally narrow subacromial space, which might result from the shape of your acromion, thickening of local ligaments, or bony changes like osteoarthritis. When this space is reduced, the tendons and bursa are more likely to be pinched during shoulder movements. Secondary impingement is the more common cause, and this is basically due to a weakening of the rotator cuff. The way I describe this to my patients is that the shoulder is a ball and socket joint, but unlike the hip joint, where there is a deep socket which keeps the joint very stable, in the shoulder the socket is small and shallow. It's a bit like a golf ball on a T-peg. This allows for the huge range of movement in our shoulders, but at the expense of stability, which is why the shoulder is the most commonly dislocated joint in our bodies. And by contrast, the hip joint rarely dislocates. Now, the main function of the rotator cuff is to keep the ball centered in the socket, while the larger power muscles, like the deltoid and the pecs, move the shoulder through its range. But if the rotator cuff becomes weakened or degenerative, then that fine control is lost. The shoulder joint becomes slightly unstable and the tendons start to rub and become irritated more easily, leading to pain. So in both types of subacromial shoulder pain, the rotator cuff and bursa are being impinged, but for different reasons, one structural and the other functional. But the good news is that whatever the cause in your case, the problem is usually very treatable and will often fully recover without the need for surgery. We just have to get the pain under control and then rehabilitate the rotator cuff. Simple. Subacromial pain is usually diagnosed clinically, based on your symptoms and a physical examination. Imaging can sometimes be helpful. X-rays can check the shape of the acromion and the subacromial space. Ultrasound or MRI can provide more detail about the health of the rotator cuff tendons and identify any tears or fluid in the bursa. But here's the important part. Scans often show abnormalities in people who have no pain at all. Degenerative changes and small tendon tears are really common, especially as we get older. So a scan might look dramatic, but it might not actually reflect your symptoms. There are some other shoulder conditions which can mimic subacromial pain, and so I'll quickly go through some of them. The first is frozen shoulder. But the key difference is that a frozen shoulder is often very stiff, particularly external rotation, which is usually very restricted. I've done a separate video all about frozen shoulder, which you can check out up here, or I'll put a link in the description. Another condition with similar symptoms is shoulder osteoarthritis, but a simple X-ray will usually rule that out. Sometimes shoulder pain can also be referred from the neck, or you might have a trapped nerve in your neck, but in these cases the pain will usually be felt most strongly in the side of the neck, and it might radiate beyond the shoulder into the forearm and hand, where you might also have some numbness and pins and needles. Okay, so let's talk about what you can actually do to help get this problem better. And there are 3 key areas we're going to focus on. First, reduce the aggravation. Now that doesn't mean total rest. In fact, that can actually make things worse, but it does mean cutting back on the things that clearly flare up your pain. In the world of MSK, we sometimes advise patients to push through pain, but not so for this condition. Persistently aggravating this problem will just worsen the pain and delay your recovery. So avoid activities like repeated overhead positions, heavy lifting, or sleeping directly on the sore shoulder when it's really painful. Often, just modifying how you move or adjusting your activities slightly can make a big difference. Second, manage sleep and daily life. Shoulder pain can make sleep miserable, so try placing a pillow under your arm or hugging a cushion to reduce pressure. And during the day, don't keep your shoulder too still. Gentle, regular, pain-free movements will help recovery. Third, start the rehab. Now this is the important bit, and I've gone through a full program of exercises from start to finish on a separate video which you can find up here or in the description. So after you've watched this video, come back and then pay close attention to the exercise 1, as that's really where you're going to make lasting improvements for your subacromial pain. If you've been doing the right things for 6 to 8 weeks and your shoulder's not improving or is getting worse, then it's time to see a physical or physiotherapist. They can assess your movement, adjust your rehab, and rule out other causes of pain. Every case of subacromial pain is slightly different, and sometimes a tailored exercise plan designed specifically for your individual shoulder is the best option. Ultrasound or MRI can be useful if your pain has lasted more than about 3 to 6 months, it hasn't improved with treatment, or if we suspect something like a full thickness rotator cuff tear after an injury. But as I mentioned earlier, don't be too alarmed by scan results. Many findings are incidental and don't necessarily correlate with pain. Steroid injections can be helpful, particularly if pain is stopping you from sleeping or doing the rehab. They're not a cure, but they can provide a valuable window of pain relief that allows you to start moving again. They work best when combined with a structured exercise program. So if pain is a real problem for you and it's not improving over time, and if it's stopping you from progressing your exercises, then an injection could undoubtedly be really helpful. And I will offer one to all of my patients in this situation. In my experience, I get much better results doing the injection under ultrasound guidance because I can directly target the subacromial bursa, which is usually the pain-sensitive tissue in this condition. Surgery is very rarely needed for subacromial pain. Procedures like subacromial decompression used to be common, but research now shows us that they don't improve outcomes any better than rehab over the long term. But if you tried everything else and the pain is still a real problem for you, then do go and see a surgeon. The decompression procedure involves shaving off some bone from the undersurface of the acromion in an attempt to increase the size of the subacromial space and therefore reduce pressure on the tendons and bursa. Surgery has also got a role if there are large deposits of calcium within the rotator cuff tendons, something we call calcific tendinopathy. Small chunks often dissolve away over time, but the larger ones sometimes need surgical treatment. Also, if you have a full thickness rotator cuff tear and the remaining portion of your tendon is still fairly healthy, then surgical cuff repair can be an option. But I've seen many people over the years, myself included, who have full thickness tears seen on ultrasound and MRI and yet have no pain and have full shoulder strength. So cuff tears don't always seem as they appear, and they certainly don't automatically need surgery. It's also worth noting that in the over 70s with rotator cuff tears, the remaining tendon is rarely of a quality suitable for surgical repair. Cuff repair failure is unfortunately a common problem in older age. So before we finish, let's briefly touch on some of the newer and emerging treatments being explored. First, PRP or platelet-rich plasma injections. So these use your own blood components to try and promote tendon healing. Some studies show promise, others don't. It's still considered experimental and not routinely recommended for subacromial pain, but it's unlikely to cause any harm. Second, heavy isometric loading. So this approach uses static exercises, usually with heavy weights, in a way that can help reduce pain and improve tendon strength, especially in long-term chronic cases. Some early results are encouraging in the research, so watch this space. Third, shockwave therapy. More commonly used in Achilles tendon and elbow tendon problems, it's now being tested in shoulder tendinopathy too. It may help some people, but again, it's best used alongside rehab and not instead of it. So to wrap up, subacromial shoulder pain can be painful and stubborn, but it's usually very treatable without surgery. Modify the things that aggravate it, start moving and strengthening the shoulder gradually while respecting pain, and get help if it's not improving. With the right plan, you can absolutely get this problem better. If you found this video helpful, then please give it a thumbs up and subscribe for more evidence-based MSK advice. And as always, if you've got any questions, then drop them in the comments and I'll do my best to reply. Thanks very much for watching, take care and bye for now.